Okay. I think Ashley's going to start us off as she is in a BHCM role and talking about her experience on systematic caseload review day. And then we'd also love to hear from others who are currently in a BHCM role or previously have been in a BHCM role. I know there's some of those folks on the call. So yeah, thinking about what any pearls, tips, tricks, strategies that you used for making your systematic caseload review an effective and efficient process. So want to start us off, Ashley?
Absolutely. Hi, everyone. So, I really look forward to systematic case review day. Um, I have 2 days with our psychiatric consultant, and we actually call SRC Psych Consult. So we call it like Psych Consult Day. I'm sure every system kind of talks about it differently, but we all know what it is. So I'm in the BHCM role for 2.5 days and administrative the other days in the manager role of the program. And so wanted to just share my experience having been in this role for multiple years and, worked with different psychiatrists and really what I enjoy about systematic case review day and, providing, pertinent updates for the patients I care for. So we utilize Epic at Hartford Healthcare, which I'm eternally grateful for. And, like most BHCMs, right, we have a currently enrolled report, a registry, also known as a registry. And so I always pull that up on SRC Day. It's important for me too to cross-reference what's on the registry versus what's on my schedule. So like, for example, tomorrow, I'm going to meet with our psychiatric consultant. And what I've done today is I've looked at the registry, seen folks who haven't been improving, new folks to the registry, folks who I know are in the middle of a cross taper, right? And they're due for that interval update on next steps. And I also make sure I'm accounting for patients that I'm seeing this afternoon. And so, I make my little list that I have and my priorities. I think it's important to note are, of course, new patients, right? And like I mentioned, anyone who's in the middle of a cross taper, we usually do every 2 weeks where we make adjustments. And so oftentimes if a patient is doing well with a cross taper, like tolerating any side effects, etc., our psychiatric consultant will give us like a month plan, like in 2 weeks do this, and then in another 2 weeks do this. However, if someone is really struggling with the cross taper, I'll only have instructions up until that particular, week, and it's time to meet again. And so those are patients I prioritize to get next steps for not only the primary care provider and the patient. Certainly I prioritize patients who, I've had a recent medication check-in and they're not tolerating a new medication well, despite, all the psychoeducation around make sure you're taking it with food. Oh, if you're taking it in the morning and it's making you drowsy, take the Zoloft at night and see how that works. Or if you get a headache, treat it symptomatically, right? All the classic education we provide. If side effects persist, those are absolutely patients that I'm going to prioritize. And of course, it goes without saying, but it's important to say any safety concerns. So if I have a patient who is waiting to get into an intensive outpatient program, if there's, active suicidal ideation, and that's really important to keep our psychiatric consultant updated in case we need to change course. And certainly, for our folks on the registry who have, worsening, their PHQ-9 GAD scores are worsening. Maybe we switch them from Zoloft to Lexapro, and it is, now they're maybe having some hypomania symptoms, etc. Absolutely, I'm going to prioritize those. So those are just, how I think through, building my list of who I'm going to tell stories about. I really like to, think about, okay, why am I bringing this patient forward today? what is going on and making sure I have an answer for that. With using, Epic, we have the benefit of what we call the blue sticky note. It's like the behavioral health care team sticky note, where I always make sure I look back on our psychiatric consultant's last consult note to make sure I have answers and updates for every single care plan recommendation so I can speak to. I also look to see if there's any psychoeducation, around if someone is, for example, I have a patient who is trying to get pregnant, right? And I've had to provide a lot of psychoeducation around, SSRIs and, research, and our psychiatric consultant trusts me to make sure I'm providing that accurate education. And so she will put in a blue sticky note, that's what we call it in Epic, verbatim what I can, share with the patient. And I really like to, when I'm on the call with our psychiatric consultant, ours is Dr. Rosengren, who is hopefully enjoying her well-deserved vacation today. Usually she's on these meetings, so I hope she's not here. But I like to set the stage in terms of, we're meeting, I have 2 intakes today, I have 6 follow-ups, and I have 1 graduation. I think it's important I feel like I'm responsible to help her conceptualize the time that we're going to spend together, and get in the mindset of, what I'm bringing forward. And so then in terms of, how I'm reporting out on patients, I always, keep in mind, I am, I am advocating for the patient, right? Like, I'm making sure that I am reporting objectively. And certainly I can share, verbatim patient's subjective report, that they feel their anxiety is less because now their stomach only hurts 2 days out of the 7 days a week. And before it was 5 days out of the 7 days a week, when they were on their way to work, an example like that. So I do tell the story. I start with the, subjective report. The patient feels this is what they're reporting. Because I think, I always tell patients to, when I provide psychoeducation around any changes in their BHCM and GAD-7 scores, right? Numbers aren't everything. However, they're part of the story. And what you feel subjectively is equally as important. And it's always, a great day when both of those match. And so I not only start with a subjective report, I give an update on the medications, any additional items such as medical updates like, oh, you remember that sleep study they were waiting for? They finally did it. Make sure I'll give the psychiatric consultant a heads up, say, take some time as we're talking to look at the sleep medicine note. I will give her a heads up to refer to the medical record because she likes to look at the outcomes, whether it's a provider, primary care provider visit. They recently saw cardiology, et cetera, anything that's pertinent to the care we're providing. And she finds that to be beneficial, that I'm prepared to let her know what additionally could be helpful for her to review in the chart. And certainly labs are important too. I certainly provide the updated, PH9 GAD-7 scores. And one thing I really like to do with my patients is I ask them, what questions do you have, for Dr. Rosengren? Because they're well aware she's part of the care team. They know they aren't seeing her. But I want them to feel as though they can ask whatever questions they want. This is their care, right? They're the center of the care. And so, at the end of my presentation on, various patient, I will ask the patient questions in their own words for Dr. Rosengren to respond to as she is documenting concurrently the updated consult note in our electronic medical record. And I mentioned, before, sometimes I'll have patients who are on the verge of graduating from our program. One of my favorite things I like to do as well is for when I'm presenting Dr. Rosengren an update around goals are met, right? This is the percentage in reduction of their PH9 GAD-7 scores, very objective, data. I ask her if there's anything she would like me to tell the patient, like in her own words about, whether she's proud of them or, make sure to keep focusing on, self-care, whatever it is. And I get the sense that she really enjoys that. because she's not meeting with the patients directly. And I feel like it's my responsibility as the behavioral health care manager to ensure she feels connected to them. So there's various ways that I do that. And that's one of them. And so when I know that I am, after systematic case review, I, have an appointment with the patient the next day to create their wellness plan, also known as relapse prevention plan. We happen to have renamed it wellness plan here at Hartford Healthcare. I will let them know, Dr. Rosengren's, kind words on their graduation day. So that has been something I found really enjoyable. And then, thinking through, various skills that I've honed over the years when it comes to systematic case review. I mentioned one as I was just talking about preparing for a systematic case review, and that's really making sure I'm in the moment and thinking, why am I bringing this patient forward, today? So really always coming from a patient-centered lens, like why is it important that I get an update for this patient today to be able to move forward, and take the next steps in their healing journey. When I'm presenting, I always use patient-centered language, of course, and their preferred name, I communicate directly, direct quotes from the patient's, subjective experience, objective data from the PHQ-9 GAD or, any labs or, where they are at in their cross taper. I also think it's really important as a behavioral health care manager to take accountability and name an action plan if you've missed following up on something in the ongoing, care plan. For example, this was a couple weeks ago. I had missed asking a patient about whether they were able to pick up a bottle of vitamin D, over the counter, because their levels were historically low, and PCP had wanted them to do so, right? And I forgot to ask them. And so instead of, thinking about all these excuses of, oh, I had too many patients or I had, too many meetings or, whatever it is I could say, just take accountability. Like, I forgot this time and I have taken note and I'm going to ask them, I'm going to follow up and ask that question tomorrow when I call them at 3 p.m. to go over the updated recommendations. I keep in mind that my relationship with the psychiatric consultant is built on a great deal of trust. And that includes, right, like taking accountability and ensuring that we're all aligned on the same page in what's important for the patients we care for. So those were, a lot of the things that I wanted to share about how I navigate systematic case reviews and some of the case presentation skills. I really like to, like I said, kind of focus on what I'm responsible for, making sure our psychiatric consultant feels, included in the patient's journey because they don't see them, directly, taking accountability, being direct, and also having some fun. I think it's really important to remember why we do this work. And, we just get so excited when a patient is graduating and we can't wait to tell the primary care provider, like, hey, it's time. And the patient's so excited. And, always keeping that lens to, why we are doing this work. And I feel as though, that's always important to remember during systematic case review. Annie, do you think I hit all the topics?
Yeah, I think you did. I loved hearing your perspective just on a day-to-day basis and how you prepare and how you what you bring to the table. And I just think all of that was really helpful. I especially like that you're, capturing specific questions from the patients themselves to bring back to that psych consultant. I found that happened all the time, but I hadn't really thought of, what messages does the psych consultant want to relay back to the patient? And I really love that. So I think that, you just have a way of kind of bringing the whole team together, even when there's a team member that they may never meet. I think that's pretty great. Yeah, so anyone else on the call who is in a BHCM role or has been in a BHCM role in the past, have any just pearls or nuggets they would like to share about, just their strategies or what's helpful? It can be just kind of one strategy or tip, or it can be a couple, whatever you want to share.
I guess I'll jump in on that if I can. One of the things I've seen that helps SCRs work well is if it's not a hierarchical relationship where, like say the psychiatrist knows more or presents that way, because oftentimes it seems like, the primary care doc gets some parts of information, the BHCM gets different views on that. So bringing it all together as a real team, I think is one of the keys to really getting a good SCR outcome. I don't know what people's thoughts on that, or if they had any opinions on that.
I agree. I think patient, the BHCM has a lot of knowledge, brings a lot of knowledge about the patient to the table. And the psych consultant has other knowledge that BHCM does not have. So, I mean, both roles are equally important. And so I like the kind of level playing field. I did have, oh, go ahead, Ashley.
Oh, I was just gonna say, I highlighted, that I asked our psychiatric consultant, patients that question have. I too, certainly have questions that I'm asking Dr. Rosengren, throughout, do you think it's time to augment? Do you think it's time to switch medications? What treatment modality and therapy do you think they would most benefit from, as I'm searching for a community provider, right? There's various questions I ask too, which I think are important to make note of in terms of, kind of learning how to navigate for my own knowledge, right? Like learning from the psychiatric consultant and making sure that I'm, advocating for the patient and, patient-centered care by asking the right questions too. And Monica trained me, by the way. She put in the chat.
Yeah. Credit where credit is due. I threw up some questions to just mull over, but you don't necessarily have to stick to these, but just want any thoughts on, the lessons you've learned, strategies, best practices. I know when I'm training new behavioral health care managers, I definitely make sure they understand that one of the roles of the or of the psych consultant is to ask questions, and it's not necessarily a reflection of how well they did or if they brought the right. I mean, ideally, we want them to bring, the right information to the table so that the psych consultant can make an informed decision around recommendations. But there are definitely times where that's not possible and they have additional information that they need you to go back and get, or and that's just that is part of their job. So, but I do think it's helpful for BHCMs to understand that so they don't feel like it's the criticism of their work or how they're doing, because I've definitely had a few folks that impacted the relationship out of the gate, and that dyad, and as Ashley mentioned, that trust is so important. So I think just making sure everyone knows that's literally their job, to ask you a bunch of questions and get more information, because you're the expert on that patient. You've spent quite a bit of time with them. I would say another kind of strategy that I used as when supervising BHCMs was to periodically check in with my psych consultant around any training needs that they had identified for the BHCMs, especially when there were newer BHCMs onboarding. And so I would get a really great information, like this group could really benefit from, differential questions for ruling out bipolar disorder and things like that would be common information that the psych consultant needs them to bring when they're presenting cases. But if there's just missing pieces or a lack of comfort, then I could often get that information from the psych consultant. And so that was kind of one lesson I wanted to relay. Anyone else want to share any just lessons or strategies, best practices around their systematic caseload review? Oh, there's lots of stuff in the chat.
Well, I think I just wanted to mention, so Sam, thanks for asking the question. Does anyone have strategies or ways that they have had PCPs participate, primary care providers in systematic case review? And I wish so much that the PCPs that I work with throughout our system were given the time to join these. We haven't gotten there yet. I'm curious, if other folks on the call have the primary care providers or other, treatment providers that you're supporting join systematic case review.
Monica?
Yes. Hey, everybody. It's good to see your faces. I have had PCPs join, particularly prior to your time, Ashley, at Hartford Healthcare, especially when we were first starting out and we found that there weren't a lot of providers referring patients. So we did two things. We started doing academic detailing, but we actually would then staff one of the cases, like right there with the providers, and it would be one of our providers who was there. So they were able to kind of chime in, but we would use that case, the psych consultant would, to then provide whatever didactic information about certain medications. So we did academic detailing, ended up having the PCP involved that way. And yes, I did count the minutes because we were talking about their patients. So there's that piece of it. And then I did start to have some providers, not many, but there were a few that sometimes they just want to ask some questions directly to the psych consultant. And I recognize the importance for some providers, some medical providers, to feel like they have that connection with the psych consultant. So we actually started doing onboarding where the site, like there would be a time that a new PCP would be scheduled to meet with me about collaborative care, and I would try to see if the site consultant could hop on for 5 minutes so that there was at least a little bit of FaceTime, because I recognize the importance of the FaceTime. But in the situation where the PCPs just wanted to talk to the site consultant directly, all of the PCPs know when SCR is, and they were free to just drop in anytime in that hour. So if we were in the middle of discussing someone else, we would stop to discuss that PCP's case because they were hopping on. Sometimes they were hopping on in between, going from a room to a room. Oftentimes, I will say, our systematic caseload review was not held during the PCP's normal lunchtime, which if they even really get a lunch, because we all know they're usually charting a bunch. So we didn't have our SCR during that time, so that could have been something that we tried, but we more tailored to our site consultants' schedule because they were wearing many hats. But our PCPs knew when it was, and they would just pop in. And when, like I said, when they popped in, we would stop whoever we were talking about to turn our attention to their patient, answer whatever questions, and then that was kind of it. Our site consultant also quickly recognized the PCPs that needed a little bit more encouragement than others, the ones that were a little bit more hesitant to prescribe certain things. So oftentimes, yes, they would send the note, but then they would send like this extra little message to the medical provider that would be like, you're doing a great job, like prescribing for this patient. We could see the outcomes, kind of to give that little extra bit of support, which I also think was really helpful.
I can follow up in a PEDS example. We actually had, like you were talking, Monica, but we had 4 to 5 pediatricians join us every week for probably much over 2 years. And one of the most amazing things that happened there was that the learning from one patient, example would then move out to the rest of the patient population because they had an example of how that worked out and how to manage it, how to cross taper, how to add meds, things like that. So especially with the harder cases, they moved to to be more comfortable with medications that they weren't typically comfortable with before very quickly. So it's an expensive meeting, but it was really interesting.
Yeah, I'll
Yeah,
chime.
that's a great.
Oh,
Go ahead, Jen.
no, I was just going to chime in. So I get to wear 2 fun hats. I get to be the PCP in collaborative care and also the medical director. So I kind of see like the leadership side and then like the busy clinician side. I would just put my vote in for, yes, encourage those PCPs to, if it works for them, drop into the SCR. Know that often won't jive with their schedule. And so encourage asynchronous question. Everybody's EHR has a very easy way to document back and forth questions. Like in the chat, Stacy and Michael were talking about, back and forth directly from PCP and psychiatrist. Do that. I love that because I often have a question in clinic and I know that, it's not SCR time with Dr. Norell, but I know I can shoot her a message about one of our collaborative care patients when I have a brief minute between my patient visits. I have a no-show or a quick, message at the end of the day, and that she'll follow back up with me. And then care manager sees that we've been discussing that too, because the messages are between all three of us. So it's kind of like CCing the site consultant and the care manager. So that would be my tip for that question in the chat about like, we need timely access to our site consultant. Coach them up, just like, hey, you don't have to wait for the SCR to hear from the site consultant. Shoot them a message. Please do that. And I think that only builds on their trust and rapport that they get to know the psychiatrist, feel supported by them, and in time anticipate that, I know that, Dr. Clark's going to tell me to, try lamotrigine. Okay, cool. So over time, the more repetitions you have of back and forth messaging and conversation between the site consultant and PCP, it helps. I think it really helps you just feel confident in the teamwork you're doing.
Could I quickly ask a question of everybody? So I've heard of folks, the BHCMs, that don't feel comfortable talking about the recommendations with patients. Sometimes they feel like they're practicing medicine, quote unquote. But then on the other side, the patients are typically very anxious to learn about them or get things started in some cases. Where do people stand on that sort of dilemma of like practicing medicine or working with the patient on what the recommendations are? I mean, you can't change the medication, obviously, things like that, or the dosage, but
Yeah, I mean, I think in our shop, we really normalize it like other care team members. Nursing is the big example we give. Your nursing or clinical staff isn't going to be changing medications, but they're an important piece in the communications team. Very often in the medical setting, your doc will be calling you with lab results, right? Or, you had an abnormal x-ray, you need to go to orthopedics, whatever. But clinical does that all the time. So we just try to normalize that with the care manager of, we're not asking you to practice medicine. You're not asking you to tackle tough questions when they're very complex. Send that on back to us as the PCP. But please do empower yourself to be a really smart and great and engaging member of the care team, to be a communicator right next to me so that my patient can get a quicker time response from me. If you wait on me to get around to, looking through my inbox end of day with 40, 50 messages, it's going to be a while. But if I can task my teammate, either my nursing clinical or my care manager, hey, follow up with them, let them know that we're going to up that dose from 20 to 40, boom, patients like that. So I hope that, I don't know if that, makes them feel any easier about that, Ben, but we
love
just
it.
try to support them in that role. So anywho.
That's the direction we go into, but I've heard of camps that just have absolute kibosh on it and don't say anything about it, which I don't think is very team oriented, but I love the way you explained that. So
Stacy?
One of the questions I have that we're struggling with is from the time of the systematic case review where the consulting psychiatrist gives recommendations back to the PCP, to the PCP's availability to get a patient in to make the changes. Sometimes they feel like they have to see the patient in person. The concern on their end is that it could be a month before they get the patient back in, and they feel like that's not timely enough. Wondering how others handle that, or if there's any tricks to the trade.
I mean, I think it depends on the PCP's comfort level. In our shop, and I think we had last count 39 PCPs from peds to OB to IM to family med that are doing collaborative care. A lot of them are now comfortable enough to implement a medication adjustment from the site consultant without a PCP visit, but that's not everyone's style. So we try to let room for those. I can think of a few of our pediatricians that are less comfortable with psychotropic meds and like, I really want to bring in that child and that family to talk about starting an SSRI. Great, go for it. But a lot of them that have been doing collaborative care longer get very adept at saying, hey, we work as a team, and that teammate, the site consultant, really thinks we could adjust it this way, and doing those asynchronous med adjustments. Like that's how I do my shop. And it's not that that's the right way. I do a lot of adjusting and phone call back and forth with, here's how we're going to adjust things after the SCR without waiting to see me. Because to your point, it would take 6-8 weeks to get in to see me. If we had to wait for everybody to have a face-to-face conversation with me to adjust things based on the SCRs, we would be a really inefficient program. So we've really come to rely on a lot of telephone, calls back and forth in between. And patients have come, I mean, most of them like that. They like hearing from us quickly. They like feeling that we're on top of it and adjusting things. And some of them have tough questions. And occasionally I'll give them a call, or we'll say, you know what, this person really does need to hop on for a double book and come have a face-to-face chat with me. That's fine. So.
Stacey, I've often seen it differ between, like, if it's a different medication or a different class of medication or the taper kind of issue, but usually most docs I've worked with, if it's just an increase, they can do that through asynchronously.
I know I would, when I was a BHCM, I would try to kind of look at when they were last seen. If they were just seen, especially, and it was quite a bit out until they would be able to be seen by that PCP again, I would say, you saw them a week ago. I have them on your schedule for 7 weeks from now, and I have this number of visits with them where I'll be checking in on tolerance and looping you in to how they're doing. Are you comfortable starting this at this point? And so often they were, knowing that I was it's not that they aren't going to be seen. But there are naturally fewer visits with the PCP when you add extended members to the team. But I think that seemed to be helpful to get people to, but I think you ultimately need some flexibility, because flexibility for the PCP style, but also what the context is. Like Ben said, if it's just a dose change, do you need a visit? And so, to not have maybe standardized approaches, but flexibility for what the options are, I think is always helpful to move things. The goal is to move things fast.
I like that. Thank you.
I have heard of other shops that will work with the front office staff to kind of hold on to some no-show opportunities, and then BHCM sort of tags them as theirs and then pushes the patient in there for those med checks.
If I could just add, and I put a little bit in the chat, Stacy, so I'm glad you raised your hand. So for us, our primary care providers have a pretty strong relationship with the BHCMs, and, in our primary care culture, there really isn't that flexibility for them to have them come in to go over, every update in the plan of care with dosing, et cetera. So they rely on the BHCMs to update them around what the patient is agreeable to. And so that has been really helpful to minimize, additional visits with the primary care provider that can be, easily addressed by the care team itself. I would say the exception to that is, for controlled substances. If we're starting someone on a stimulant, certainly the primary care provider will have the patient come into the office to sign a controlled substance use agreement. But that has been, the PCPs have found that really helpful, because when they're first starting and they don't necessarily understand that's, how we approach it, they get really frustrated around, like, I don't know when I'm going to have time to tell this patient. The nurses are already so busy with their in basket, et cetera. And so that's been really helpful for, for how we're doing it in our program.
Thank you, everyone.
All right, maybe I'll take us to, we have another set of discussion questions that are more related to numbers and metrics, and what information probably from your registry can help kind of monitor quality of your systematic caseload review. So just wanted to hear from folks of what they look at to measure, to monitor and evaluate the effectiveness of their SCR, if people have specific metrics that they look to for that.
I'll share one. I don't know that it's right though. And so I'm just grappling with how we're operating in our systematic case reviews right now. But one of the ask is that we review all patients at least monthly. And that's hard. Right now it's easier because we have a dip in referrals and a dip in volume. So it's a little bit easier. But when we're operating at full speed, that's hard. And I don't know that that's really necessary. So just sharing that. Open to feedback.
Anyone else have that approach of a monthly,
Yeah.
Ashley?
So
Okay.
Stacy, my heart goes out to you.
Yeah.
Yes, the same, our compliance, and it's specifically because our compliance department has requested that. So I just wanted to say, to validate, like, that can be really hard.
And
Go
yeah,
ahead, Michael.
I just want to say that, our compliance department has said that all the patients being reviewed on a monthly basis is not a requirement, that as a psychiatric consultant, we can target the patients that need to be discussed, right? So we're not under that same onus
That
that
came out of
others are.
Medicare, that CMS put in the guidance that the cases had to be reviewed each month. They have since said that is actually not necessary. And Monica has it, I have it, the AIM Center, and I think some folks had gotten it some time back, where CMS, in CMS language and from CMS, says that's not actually necessary. We do have some language into them to change the MLN and some of the guidance, so hopefully that will be a little bit clearer. But if anybody doesn't have that or wants to go back to their compliance, Monica, you could share it or I could share it, either way.
That would be
Yeah, I
awesome.
think it's definitely one of those things where you have to advocate. I was at the system that Ashley now leads, and the number of times that I got pulled into meeting, things would go well for about 6 months, and then all of a sudden it would be somebody new in compliance or somebody, we even had legal at the table, because this does end up coming down to how someone else interprets that sentence. That, honestly, you guys, this is what it comes down to. And so I was the person that was like, hop on these office hours and ask for yourself, and all the explanations to try to get them to not. Now, what I will say, the initially what they wanted was for the medical provider to sign every piece of documentation every month, before every bill every month. So let's be very clear that although it is tedious over there, Ash, that's a win compared to what they initially wanted. But we have to have conversations also around use of, like, scope. Do you want my medical providers really spending time doing that when the behavioral health care manager could do it? Like, I had to have lots of conversation about using individuals to highest level of their scope, how much cost it was, how much less productive the behavioral health care managers were going to be if you were going to ask them to do this note on every patient every month. That, like, let's just be honest about that. But it was conversation with legal that pulled them back off of the PCP has to do a note every month. But they were really stuck on that last piece. But like Verna said, this is about what was in the language before, how people have interpreted. That is not the case. Oftentimes what I say to people is, it says they have to be reviewed. If you're a psych consultant and your behavioral health care manager have access to the registry, they are reviewing every patient because they're looking at the registry. Yeah. So every patient is being reviewed. Every patient doesn't have a case review, but every patient is being reviewed because you are both looking at the registry every month, every time before you get on SCR. Earlier Dr. Clark had said, like I look at my registry, right? Like, everybody should be looking at that. It's not just the responsibility of the behavioral health care manager. So every patient is being reviewed if they're on the registry.
But Monica, the very small thing that you did right there is you said reviewed and case reviewed. You identified a difference between the two. And the reviewed is what you're saying is the registry basically, and going through the registry. But then if we changed our language and followed that to case review versus review, there would be more, I think, understanding with folks, how to interpret those CMS guidelines. I don't know if anybody agrees, but this is a sore point for me because I think it was all
I think they're
developed.
they're different for sure. And I think that review includes consideration for
Right.
being brought to the table during the systematic case review. But it doesn't mean that everyone is prioritized, and it really impacts the efficiency and the effectiveness of your caseload review if you're not able to just prioritize based on clinical necessity. It's probably going to be a much longer meeting, which takes away from everyone's time. But yeah, I think that's a good distinction to make. They're very different, but everyone just by being on the registry is considered every week.
Yep, I agree. We had a hard time, like people really didn't get that. We're like, think of it like the pop health piece is all 60 people. You have eyes on all 60 because you're seeing their name, their PHQ-9 scores, how long they've been in care, if they are flagged for safety, like that's considered for review. The 3 or 4, however many you get to an SCR, is a zoom in. It's a deeper dive into those 4 patients for the consultation time. So I don't know if that language helps, but it took us a while to kind of get everybody like, oh, okay, I get the difference between that scanning the population considered for review versus how many we're actually talking about in detail. I feel for you, Stacy, having the PCP document in the record every month. Yikes. PCPs have a lot on their plate. This is supposed to help them. Like whatever lobbying levers you can pull with, hey, don't make them do busy work is greatly appreciated, right? Because they're involved, they sent their patient. They're carrying out your med recommendations, but yeah, the people that don't
Like
do it
Stacey is
sometimes don't
getting
get it.
hazed or something. What's happening over there?
I don't know. They're like all up there. I don't know, all up in their Cheerios. Like, what are you doing? Yeah, it is too bad because it's supposed to be helpful, and you don't want PCBs feeling like, well, this is extra work for me. That's not good.
Exactly what it is. I keep saying we're adding burden, and this is intended to do the opposite. And
yeah.
I'm trying. It's interpretation. It comes back to, right?
I wonder, Stacy, because we're talking so much about interpretation and like wording, right? Which this is only going to help for a subset of your patients, because your patients who are not, who are in collaborative care but are not getting any medication management, this would probably not apply to them. But is the fact that the PCP is having to send in medication prescriptions for the patient that is in collaborative care based on the information received from this team, is that not directing care? Because they are the only ones that are sending in the medication. The site consultant isn't doing that. The BHCM can't do that. So does that not mean that they are directing the care because they are sending in the prescriptions?
That's an excellent point. And I don't know that we've looked at that. So thank you for saying that.
I think I spend too much time trying to pivot and find workarounds for these honest rules that are put in place.
It's important to pivot and find workarounds, but it's more about like making this work where we know it's an effective care delivery model, and the point is to be helpful and not to add, like I said, more burden, and trying to advocate.
There is one system I will say, and I don't know if this is why they do it because of this PCP direct care language, but there is one system where when the BHCM does the initial assessment, that is sent to the PCP for signature. And I don't know if maybe that's why they do that. Again, because it's not a requirement. It's not a billing requirement that that's done. But that has just brought that up for me, that I wonder if that's why they do that. That's not really a necessity, but maybe someone somewhere told them.
Yeah, we're doing that. We're sending the new assessments over for signature, but that is just new assessments. And then any document at the end of the month that the BHCM notices that the PCP hasn't had any communication in the chart about the patient, she'll send like an overview note to them for co-signature, which again is okay, but it's still like not necessary.
Any other barriers that are limiting folks' ability to do the systematic caseload review efficiently and effectively?
I know I've bothered both Annie and Monica about our shop around small caseload size. We have programs that have clinics that have adults and kids, and there's far more adults. So we have very few kids and a separate psych consultant for that. And just bemoaning the fact that sometimes drift happens quickly where, well, I've got 4 kids. I don't need to meet with the psych consultant every week. And we're figuring out slowly but surely. I think we've come to a compromise around an every other week cadence, but that was a real sticking point for our team where I mean, I get it. Like, we don't want to waste our time, right? If nothing's changed with these 2 kids week to week, so we're really threading that needle. But just shout out, Annie and Monica are awesome with like problem solving stuff. So apologize for email blasting you all the time with these types of whiny questions, but it really does help. So thank you.
We love the blast.
All right. Thank you. It really helps though, and it helps having your expertise. I will say that because I don't know about you all, but there's something about the can't be a prophet in your hometown. I can say something in my system and they're like, yeah. But if I'm like, well, Monica and Annie at Ames Center, the National Harvard of Integrated Care said blah, blah, blah. They're like, oh shit, we better do that. So sometimes it helps just to have an expert in your pocket and have someone to say, hey, look at this, guidance from, national experts and coaches. So sorry if that's going to make more emails for you ladies, but it really did help me. So thank you.
We are developing a directory for this very source, very reason. So
cool.
Sam had
has her hand up. Yeah.
Thank you, guys. I really appreciate all of this conversation. It's really helpful, and it's coming at a time when we're like really thinking about this in our like QI and how we can help make do our case reviews a little more efficiently. This is feels like a really basic question. Right now we're using Word to prep and take notes. The BHCM is the one that's steering that document and taking notes. It's a lot of information to have on a screen and bringing cases to review. I'm curious, what systems do you guys, and there's also a lot of challenges with carrying information forward to another review just based on how it's organized right now. So I'm wondering how other people organize, what program are you using Word to, do you organize it by patient? And then you just have agendas and you bring up kind of the patient's records, or are you prepping new stuff each week? So some of those really operational specific questions on how you organize all the information that you're discussing in the case review session.
Are you saying if you don't have a registry that does that automatically?
I guess so. Can you say a little bit more?
So if you have a registry that prioritizes patients for discussion, right, then you would just go down the list. Is that
Yeah, I guess so. Maybe I missed some of the discussion that was happening. We have a registry that we're using, and it is helpful for patient tracking, but there I think are a lot of opportunities that we're not using it in that way for case review where we're pulling up the registry. The BHCM is the one, I'm the one who's kind of prioritizing patients based on their treatment plans.
I think that's part of the problem is that, initially the registry, that was the core reason to sort of have a registry that would help you prioritize patients for review, prioritize patients for outreach so that you could pull up and say, oh, this person isn't getting better, this person is at high risk, and sort of have that in front of you. And I think, unfortunately, there's been a drift, to use the word used recently, and a lot of the registries don't have that functionality. And so then they become oh, I have to update the registry, but it really doesn't do a lot of the things that I need it to do. And so I think that's become kind of a core problem.
Well,
Yeah.
I'm sorry if I missed this before, but is it those scores that you guys are looking at? Because I would say sometimes it's scores for us, but sometimes there's a lot of other things that would be a reason to bring somebody for review. So I'm trying to think of
Well, Sam, I think that's what what exactly where you're going now with the other things outside of the scores is exactly also what Verna is talking about. Like a real functional registry is more than the scores. You're able to see when the last time the patient had an updated score, when's the last time the patient was maybe staffed with SCR, are their scores not doing well and they haven't been staffed in X amount of time, it's time for me to maybe staff them. You're able to see, is this patient less engaged, is my behavioral health care manager maybe less engaged with this patient, and there's a strong correlation between engagement and patient's outcomes too. So it's definitely more than just the score. But like Verna's 1,000% right. I think people knew they had to have a registry because that was a part of the model, but don't always really think about the functionality. So sometimes when I've worked with people and they say like, we don't have a big fancy registry, we're just using an Excel spreadsheet, I go, okay, well, you got a registry, and it might not give you red and yellow, and like some of the registries are amazing because they like give you flags, like these are the patients you need to address because you've already set up some prioritizing within your organization of what you all want to prioritize for the patients to staff. But even if you have an Excel spreadsheet, you could filter. You and your team could decide, here are the patients we want to prioritize when we go to SCR, and then that's what you filter for and look for. Those patients that meet whatever metric that you and your site consultant and the rest of your team have decided you want these to be the patients that are priority. Because every patient can't be priority. Every patient is going to have something going on, but every patient can't be priority every SCR, or you will never get through everybody. So trying to decide that is really important, and the importance that your site consultant could see it. Because sometimes as a behavioral health care manager, I have this one lens. Here's what I'm looking at, and here's who I think we need to prioritize. And then my site consultant would be like, well, what about Monica? Because I see this, and this happening with the minutes and her scores and her last PCP visit. And I'd be like, oh, well, maybe she's coming in next week. Can we wait until next week to staff after she comes in to see the doc? Or maybe I missed it. And so your site consultant also has a lens that they carry when they're looking through. So it's important to have that piece too.
Yeah. Sam, when you say you're documenting in a Word doc, what are you documenting? Of curiosity, is it like what was discussed at the SCR? Or maybe that would help kind of
Yeah, this is really helpful. Thank you guys. And it's like helping me kind of contextualize how I'm thinking about it. What we're docking, like right now, the process is that we kind of like prepping like kind of the case, and then I'm coming with really specific questions, and then if it's an initial presentation, it's like documenting kind of the treatment plan, which is then like put into a treatment plan and shared back with the primary provider. And then so, or like if there's medication adjustments, if it's a follow-up, a lot of, if there's
Yeah. Okay. Yeah. So is there a place in your EHR where you could do that same documentation? My thought process is then you're not double documenting. You can look within the chart and say, okay, I talked about Joe and we discussed this at SCR. Then it's in the health record. You see it, I can see it as PCP, and so can the psychiatrist. Do you have a place to do that, whether in a progress note for you as the care manager, or maybe like a asynchronous like workload message? Is there a place on the chart to do it there versus a Word doc?
Yeah, in our system, like we're a new program, so we're like kind of building all of this out right now. And I do think that question is one that's like really worthwhile to bring back to the team and ask, because so yeah, thank you for that.
Just one thing to add to that, I can tell you that preparing an elaborate kind of case presentation for each case you're going to bring to the table, it isn't super sustainable. I did that and it's really time consuming. And then when your caseload is full and you're going to be talking about 8 patients, that's a tremendous amount of work ahead of time. So I always recommend putting your efforts into the documentation templates that are in Epic. So when I build a like initial assessment documentation template, I'm going to bring that to my site consultant and say, here's like basic initial assessment. What other information do you want me to add to this that you want to know about everyone to make your initial recommendations? So having them help you to build that, so you're bring into the table, but that should be then what you reference. So, you know, if your registry isn't kind of integrated into your EHR, which mine never was, the registry piece was at the beginning where we prioritized, and then I set that aside and we were in the EHR, but I was in the note. I wasn't necessarily preparing something separate. Like your notes should be your preparation. So if it was a follow-up person consult, the note in my treatment plan portion of the note, I wrote what the questions were for the psych consultant. So all the information was in there. And that saved me. I mean, doing all of the prep and prepping for a case presentation is not sustainable when it's a population health program and you have a lot of patients. So that's my 2 cents about preparing efficiently.
That is relatable and kind of the place. We're not quite at the tipping point yet, but that is why like this conversation right now, I'm like, yeah, I'm experiencing
into the
exactly
future.
what you're
Yeah.
describing.
Yeah.
And you may want to think about trying to get the number of patients reviewed in a meeting in mind. So I don't know what everybody's averages are, but you know, it's usually somewhere between 10 and 15. So it's pretty quick hit in an hour. So just
Yeah, I think it depends on the population and complexity, but yeah, that's a good measurement when you're looking at what metrics do you monitor to evaluate. Definitely average number of patients discussed, and that will wax and wane, but average number discussed is a good measure to keep track of. Also, how many systematic caseload review meetings are happening per month, so they aren't ad hoc or as needed. Oh, we're a minute over. Thanks for such a great discussion, everyone. I loved it.
Can I just plug the CMS proposed rule to watch the base camp because there are some incredible increases for collaborative care, but we have a chance to push the needle a little bit more, particularly with the 99493, the ACOs, and the ability to add a complexity modifier to every E&M code for every patient in collaborative care, which would really mean dramatic revenue changes. And so, please, watch for those. We're going to be getting signatures. We're going to be sending out draft letters for you to submit. Any questions, please let me know, but it's a big opportunity. And the rate increases for the 492 are legendary. So we're super excited.
Wow. Thank you, Verna.
Thank you.
Thank you for all your
everyone.
advocacy.
Thank you. End on that. Thanks, Berta.
Thank you.
amazing.
Bye.
Thank you.
Good afternoon.